All right, so we're going to go ahead and get started. This is Dave Owens, CRNA. He's going to be giving us the nuts and bolts of hemodynamic monitoring and interpretation. Go ahead, Dave.
So, hey guys, good to meet with you today. Your education team came to me concerning some invasive monitoring and the interpretation of the monitoring. It's going to be a very superficial class, so the information will be appropriate for patient for watching your patients and treating them appropriately, but this needs to be dove into at least 30 minutes each topic we're talking about, and we're going to get this done in about 15. So we're going to start off with arterial lines, proceed to CVP, Swan-Ganz catheter, transesophageal echocardiogram, which we have one right over here to demonstrate superficially again the information of what you might see, and then end up with the Vigileo monitor, which helps you determine, some of the numbers in there are so variable, but the numbers will help you determine the direction of treatment needed. So we're going to start with the arterial line here, and there's three ways and three places you can put it. One is the radial, and what you're going to see here is usually an arrow catheter, and it has a wire in it. So when you get into the artery, I'm not going to stick it obviously, but into the radial artery, and you see blood coming back, you advance the wire through it, and then advance the catheter off of it. So that's the general direction with the arterial lines. Again, a wire coming through the catheter, and then you advance off when you get blood flow flying up this tube. Okay, so the three places again are radial, brachial, if you try both sides, because you don't really want to go to the brachial as a go-to from the get-go. So you want to try both radials if they're both accessible and both functional, brachial, and then the femoral in the groin area, the three areas for the arterial lines. The standard procedure, cleaning, we use ChloraPrep with ours, even though it's still an IV sorta. We go a little bit further, and then just sterile dressing. Used to put sutures in them. We don't do that anymore. We use sterile dressing for all the arterial lines, no matter the place that we put them. And again, arterial lines are going to be for frequent lab studies. When your patient's a little sicker and you need minute-to-minute vital signs, and just overall general appearance of the patient. If you think you need an arterial line, you probably need an arterial line. And some of the ones that we use here, that you'll see, I'm showing you two because there's two different ones that we're doing. This is a simple arterial line, one transducer, and what I mean by that, and I'll show you over here in a second, if we're just using an A line only, you just need one transducer because that's all the pressure is going to be generated. This one is called the Vigileo. It's called a flow track system. So it is a different transducer from your standard transducer. And we'll get into that in just a second as well. But if you're going the whole gamut, let me bring this thing closer to you. Yeah, by the whole gambit, this patient's sick, big belly case coming to you guys. You're going to have three different transducers. One is the arterial line, obviously marked in red. One is yellow, is what's called the Swan-Ganz, and we'll touch that again, the PA pressures. And this one is the CVP. The Swan-Ganz we rarely use anymore, but we're going to address it because you may see it. But again, we're going to go from simple, one transducer, A line, if you just need to monitor blood pressures and get frequent labs, to a Vigileo if you expect big fluid changes, and we'll explain that in just a second, to the full three transducer system. And what I mean by transducer is once you put this arterial line in, and it's sitting there, the arterial line's in, and you hook it up, you have a mechanical flow banging against the transducer. So it turns the mechanical flow into here, and this it's called the transducer because this little mechanism here converts mechanical into an electrical signal so you can see the blood pressure. And that's what transducers do. They just take mechanical flow and turn it into electrical signal that you can evaluate. And all these will have those numbers, CVPs, PAs, and arterial lines. And you know the normal arterial pressures are anywhere from 120 to 140, even 100 if your patient appears stable. And let me address it really quickly. The numbers are great to have, but when you address the patient personally, that's when you're going to get the most picture. So if you see a pressure of 100 over 60, but you go in and your patient appears fine, trouble breathing, that's his normal pressure, it's okay. It doesn't have to be 120. So addressing the arterial line, the biggest thing is, I can tell you, when you have an arterial line in, is the transducer height. And it's going to be the level of the heart. So wherever the patient is sitting, guesstimate the level of the heart, because some of your cohorts will come in and go, oh, that transducer's not right. Now it's right. Really? That's not going to change your patient outcome. This will change your patient outcome, and that will change your patient outcome. Just get it level, it's all subjective, but at least level with the heart, so you have true numbers hitting off that transducer. And the biggest thing you can take away from this with your arterial line is have a blood pressure cuff as well, because so many things can dampen an arterial waveform. And it's always good to have a blood pressure cuff on to evaluate what's going on. Like in the operating room, we'll see pressures. The surgeon will be leaning on the arterial line, and it goes to 60. Patient's doing fine, you take a blood pressure, it's 120 over 60. So many things can dampen the arterial line waveform. So use the blood pressure cuff always with an arterial line. It could be on the same arm, opposite arm, it doesn't matter. So again, with that being said, transducer level of the heart and a blood pressure cuff to validate what you're seeing on the scope. All right, now we're going to go to CVP, and CVP, central venous pressure. The normal values, this is a great screen right here. When we get to this screen here in the next couple minutes, the numbers are going to make much more sense to you. But a CVP is actually a catheter that sits right in the right heart. This is a little high up. This is called a cordis, and this is what it looks like before it goes in. You'll have a little introducer into that as well. But you either have the internal jugular or a subclavian approach to the CVP, okay? But this will sit here, and ultimately, it sits right above the right heart, and that indicates fluid volume, because it's all the fluid that's coming back to the body has to go through the right atrium. So it sits right there, and it is sent back to the waveform through your CVP, which is blue. When this is hooked to your line here, it'll reflect through the CVP onto your monitor. And normal values, you can see anywhere from 3 to 12. 5 to 12 is about right. You don't want 0, because you need some volume. It's like a hydraulic. You need something to pump against. So anywhere from 5 to 12 millimeters of mercury is going to be the normal CVP. When it's low, there's a couple things you can evaluate. Are they dry? Is the heart not pumping it enough? Is it a pump problem? Is it a volume problem when it's low? So it's not purely, the number doesn't mean, if it's low, that means they're dry. There's some other variables that can go on. And that's what this Vigileo, and we'll attack that in a second, can really kind of fine tune your patient here. The last thing we'll address on this transducer is the pulmonary artery pressure, and it sits in the right heart, so it's a low pressure system. Normal systemic pressures are 120 over 80, normal PA pressures are 26 over 10, with a mean of about 15, because it measures the right heart, the low volume, the low pressure system. So these used to be the gold standard. The gold standard is now the TEE, the transesophageal echocardiogram, because it gives a real life picture of pump and volume coming through and to the heart. So again, we need to address this because you may see it, pulmonary artery pressure. So on the whole shebang here, you got arterial line, pulmonary artery pressure, CVP. You'll get every number you want. Let's go on to the Vigileo now, because this is the gold standard for us in the OR. And there's so many variables. When this screen comes up, obviously there's not a patient attached, that's why we're going to show you the chart. But when this screen pops up, this is what you're going to see. You're going to see all kinds of parameters here that can give you the information you need to fine-tune your patient. The ones that we use specifically are cardiac output and SVV, which is stroke volume variability. What stroke volume variability is, it relates the amount of volume that's actually within the vessels. So when you see a stroke volume variability, you'll come up to a percent, anywhere from 5 to 25 to 30. Just remember, high is dry. You want some volume on board. So if you get a big stroke volume variability, that means there's inconsistent volume coming back to the heart. So you're going to have trouble trying to manage that blood pressure if you don't have enough adequate volume. So we use stroke volume variability and cardiac output. Cardiac output's usually 3 to 5. Stroke volume variability, we want to see below 10%. That indicates if there's enough volume on board that it becomes a different problem if you can't keep your pressure up. So over here, fine-tuning these numbers is, if we can get that in close, if not, I can bring the screen to you.
I'm bringing it. Excuse the selfie I just did.
It's all good. Can we pick up these numbers?
I think so, yep.
Okay, great. All right, when you see that screen is right here, and these numbers right here tell me the CVP is like 5 to 12, I'm seeing a 3. Right here, millimeters of mercury, CVP, and that's going to show up over there as well. I'm seeing a cardiac index.
George Hines, please call the operator. George Hines, please call the operator.
Seeing the cardiac index of 1.9, and the index is different from the output. It's usually 2.5 to 4, where cardiac output is 3 to 5. And then I'm seeing a stroke volume variability of 21%. So if I'm seeing a low cardiac index, a low CVP, and a higher value of SVV, they're dry. You're going to be able to challenge them with a fluid volume, maybe 250 at one time to see. Now you have to evaluate your patient. You just can't go, oh, he's dry. And you go in and he's having so much trouble breathing, you can't put more fluid on him. So it's just purely an indication of what to do, the numbers initially to go in a general direction. You have to go evaluate the patient. You can't just go treat numbers. But this is tremendous on big belly cases that we're going to hand off to you guys, hopefully in good shape. That this at least guides me, okay, I'm seeing this, he's not having any trouble, I have no crackles when I listen to the lungs, he's dry, I can challenge him with some fluid volume. So again, the Vigileo, with these numbers here, the cardiac output or cardiac index and stroke volume variability, that all in itself can at least start to fine-tune your patient. So the only thing I'm gonna address here is going back from A line, going all the way through it, and then we'll hit TEE. A line again, you've got your radial, brachial, femoral. It attaches to the transducer, and it prints out a value for you to view and treat. Also frequent lab studies. CVP through a portus through the internal jugular, subclavian. And this, you can also draw labs off that. Obviously, they won't be gases because it's a venous system. But that at least allows you to measure CVP, normal levels 5 to 12. If they're low, they're dry. This is without looking at your patient. If they're low, they're dry. If they're high, they're kind of full. Meaning, again, 5 to 12, anything above 12. Swan-Ganz catheter, I will show you specifically what it is. This is what floats through the cortex. When they put a swan in, they'll put it through the cortex. It goes through the heart, right atrium, right ventricle, and lands into the pulmonary artery. That's why it's so long. And it sits there and it reflects values back here too, off of this PA catheter transducer. And a reflective value, again, a normal value 26/10. Any variables in that let you know which way you need to treat. Vigileo, incredible monitor for big belly cases. Stroke volume variability, cardiac output. And then now we're going to come to the TEE, which is really, these show numbers. This shows actual what you're seeing. This has become the gold standard for intraoperative fluid volume and heart function. You can see on this one, now in your mind you're going, well, that's the left atrium, that's the right atrium, but it's flipped upside down on this view. So this is the left atrium, left ventricle, right atrium, right ventricle. It's a 4-chamber view. So your tricuspid valve is functioning right here. Let me change that to mitral. Mitral. Hope you guys caught that.
Yeah.
Mitral valve between the left atrium and left ventricle. Tricuspid between the right atrium and right ventricle. And it's just showing it's got good, what's called concentric pump power. So if you look in here and your patient's dry, according to these right here, got a low CVP, a high SVV, remember high is dry, and then the cardiac index is a little bit low because you don't have enough volume, you're seeing that their pump is working fine, so they can probably take a good fluid challenge, 250 cc's, and you can watch the heart start to fill, and then start to pressure, the SVV will start to drop because you're filling them up, the cardiac index will probably go up, As long as you can view this, the numbers are terrific. This is real time. So you're gonna get a real life picture of what's going on here. Okay, I believe that may cover at least every one of these
Anything else?
lectures.
Nope.
Yeah,
Oh,
every one
that's-
of these lectures is 30 minutes alone. I hope this at least guides you to the numbers, pay attention to your patient, because one big snafu you'll see is you'll look up at your monitor at your nursing station, and then you'll see a pressure of 260 over 120, and you'll go in, you'll go, what is going, oh, transducer fell. So pay attention to the situation, pay attention to the patient, pay attention to the numbers, but look at what's going on around you guys. That's the gold standard. Pay attention to your patient. Thanks.